um, in response to what Dr. Ajayi said as regarding how for clients that are present in the clinic and comes with these challenges, how do we go about that?
Well, we operate at the primary care end. So most of the time, most of these clients, before they even get to you, we see them. And, when they have these challenges, we end up referring them to you. Basically, I think the approach is to handle them properly at the primary care center, have them prepared psychologically, and have them ready for what they are going to meet at a referral center like yours. So, am I audible?
Yes, you're audible. You're good.
Okay, so basically it's just to give them the proper support, counsel them extensively, give them as much information as possible, because like Dr. Ajayi said, it would not augur well to allow them to go into something. At the end of the day, you find out that the embryo the woman has been implanted with is not healthy. And there are different kinds of illnesses, single gene mutations like cystic fibrosis, sickle cell disease, Tay-Sachs disease, thalassemias, so many illnesses, even genetic mutations, trisomies, Down syndrome, Edwards syndrome, Patau syndrome, all those kind of things that at the end of the day, when the baby comes out, it will be very challenging for the parents of the child to handle the child. From joy, it turns to a kind of mixed feelings. They have a child, but they are having challenges at the end of the day. So before they even come for IVF, we prepare their minds that they have to do genetic testing along with the IVF. Yes, it's pricey in a way, but at the end of the day, it saves them a lot of money in the long run. And it's not even only the health of the baby, because you are selecting the best, even the health of the grandchildren they are going to have. They want to have a child, but the child they are going to have will have another child. You understand? So if they have genetic disorders in the family, you can end it at that point in time and select the best embryos that will not continue with the same genetic problem that the parents have. Some parents even know that they have genetic problems in their family and they don't want to have it. So that one is clear cut. So they are always up for it, this genetic testing before implantation. And another thing is, it's not just about diseases alone. Some couples want to balance their family. Sex selection is also part of it. You can be sure that the embryo implanting is female or male. That's another way to look at it. So you prepare their minds. What do you want? Do you want a male? Some even want to do sex selection at once. They want 2 males and 2 females, and they want to carry the baby at the same time. So in that aspect, basically what we do at our own end is to counsel them extensively, to counsel them and make them know what is available for them at the end they are coming. And usually, apart from gender selection, even women above the age of 35, we know that they are more predisposed to having babies with genetic disorders. So those ones too are co-opted. They are specially counseled, and they should be made to understand that above the age of from 35 years and above, the quality of embryo must be, you must be assured of the quality of the embryo before you implant the embryo. And the only way to do that is to do a genetic testing on the embryo. And then women who have recurrent miscarriages too. We all know that recurrent miscarriages in women is more often than not due to chromosomal abnormalities in
I think we've lost him. Okay. We've lost Dr. Bankole.
Yes, it's network.
I think we've lost. Yes, we've lost him.
Dr. Ajayi, I would just like to know if there are any ethical concerns or considerations when it comes to this genetic testing with IVF.
Of course, like any other thing, there are ethical concerns, you know, because I mean, for example, I know that in some centers or in some countries, you know, especially where people are concerned about eugenics. Eugenics means a situation where people create designer babies and things like that, you know. You want a particular kind of baby, you don't want kind of baby. You do not allow some to thrive because in your mind, these other ones are okay, and these ones are not. What PGT does is that it helps you choose the best, yes, but at the same time, it also helps to eliminate some. So some people will tell you that is not fair. After all, if you look at Down syndrome, for example, Down syndrome is a spectrum. And there are some, it's not as if it's not compatible with life. There are a lot of people that have Down syndrome that are living productive lives, even now, you know, where, you know, some of them are able to walk and do some things, you know. So, I mean, why don't you allow those kind of people to thrive? Why do you kill them off, you know? So there are those kind of concerns, you know, but it's the person who wears the shoes that knows where it pinches that person, you know? And I mean, for all it's what the benefits of PGT, I mean, for us, outweighs all those kind of concerns because if you look at the cost of having to take, not even financial, now the emotional cost of, you know, caring for babies or children with problems like that, then you know what it means. So we'll just, for all, I just believe that the benefits actually outweigh all those ethical concerns, but I stand to be corrected. I don't know what Mr. Wilson has to say about that.
Mr. Wilson, any ethical considerations from your side? Please unmute yourself. We can't hear you.
Okay. Okay, yes, there are actually ethical considerations, exactly what as Dr. Ajayi said. There are countries that do not even allow sex selections. It must be on the grounds of maybe advanced maternal age, that PGTA, that's aneuploidy, because it's when you're doing aneuploidy, that's when you'll be able to check the 23 chromosomes, where in the long run, you're also able to check the sex chromosomes also. So there are countries whereby it's frowned at for you to actually do sex selection, where in some countries they call it family balancing, which technically it's acceptable to an extent. But well, let's bring it home for us here. I don't think there is any law outrightly saying you should not do family balancing. So like here, we call it family balancing also. For some reason, some people prefer to do that. But ethically, there are some things that is not allowed in PGT, that if it's you're trying to create designer babies, a particular baby with a particular high, some traits, and it is not accepted. So I think for now, those are some of these the ethical considerations.
Let's talk cost, but before we go into that, please, we'll encourage participants with questions. So please type their questions in the chat box. We'll get to the questions shortly. Mr. Wilson, talk to us about cost. How affordable is this genetic testing?
So, well, cost is relative. And from centers to centers, you cannot put cost, but there is also what they call the baseline cost. I working over the years with clinics, it you know, you cannot.
You'll need to unmute him. I think it's muted, okay?
Okay, sorry for that glitch. So working with different clinic always have their cost, but I can tell you in Nigeria on average it ranges between say $10,000, probably above. Because one, most of the time, yes, even in Nigeria, we have some centers that run those stuff directly. And why the cost is huge is because some of the things required for running those tests has to be in volumes. So when they are not run in volumes, unlike other countries where some of these tests for advanced age is routine. Someone going through IVF, if you're above 38, going to 40, is more like a routine thing. So they deal with volumes and it's much easier. The cost is reduced. So if it will be difficult for me to actually put a specific cost to PGT. As I said earlier on, from centers to centers, it differs and is not pocket friendly, but it's worth the while. I will leave it at that.
So sorry for us to interject. Like I said earlier, you're talking in terms of say $10,000 and all kind of things. But I was trying to say that if you're going to, the most popular one is sickle cell anemia.
Yes.
You're going to do bone marrow transplant for sickle cell anemia. You'll be spending upwards of 100,000 US.
Yes.
That's even if it works, because it's a very risky procedure and there are so many possible complications. So I mean, for us, the cost benefits ratio is actually very, very high, because I just think that the benefits that you get from screening, at least from knowing, helps you to plan. I know some people, I've seen clients who knew that they had sickle cell babies and still went ahead to have the babies, because they intend to do those other, major, and they could afford it. But what about those ones that can't even afford it? We can't legislate love. A lot of people are AS, they want to get married. You can't stop them from getting married when they want. There's no law that says they can't get married. But they should be aware that it's possible to screen prior to even having babies. If you're able to screen for babies, you save yourself the stress of having to manage, sickle cell anemia, because it is actually very, very devastating. And people that are in love at the beginning, when they start having babies that take them to the hospital all the time, might fall out of love very, very fast, because it can be very, very frustrating. But so if they know that they can actually test before even getting pregnant, I think that's a big plus. And there are a lot of people that wouldn't mind, knowing before, going ahead. So it's I mean, if it's something that you think you want to do, then I'll suggest you go ahead and do it instead of wasting
Sorry,
time.
Dr. Ajayi, to interject also. I think the range of the 10,000 I'm even talking about, I'm just talking about PGTA.
Yeah.
Not
the IVF.
Yes, not
Not PGTM.
Yeah, not PGTM, because that's more, as I said earlier on, it's to an extent is more complicated than the just screening the chromosomes. And as Dr. Ajayi said, it's something that is worth the while. Many people go into this and I'm in love. I'm in love. I care, and when the challenges and trial comes, it's the love dries, as in dies, like, because it drains your pulse, your emotion, the emotional cost. There are a lot of things that your life also is on hold because you are stuck, because you need to give attention to the child, you need to source for funds, and at times this actually ruin people's life, and so it's worth the while to check before we also advance. Yes, as regard the cost, I know we've not gotten there, but at some point, which happens with other in some other countries, whereby there are legislations that backs some certain things, because one, when you birth an unhealthy child, it puts stress also on the health system, because the health system also will have to come into place to take care of those children. So they put systems in place to even forestall, to prevent such occurrence. But I know, we are a unique country, and we'll get better when legislations are put in place. Insurance are also there to cover, to an extent, some of the costs, and things will get better, because it's something that everyone that intend having an healthy baby should have access to.
Thank you, Mr. Wilson. So I was going to ask Dr. Bankole this, but Dr. Ajayi, you also see these couples when they come in. I would like to find out from what Mr. Wilson said earlier. There are some couples that when they get the results of their screening, it's not favorable. What support is available for these couples? What advice would you give to them? How do they carry on?
Yeah, it's always very difficult to deliver bad news, and it's in all aspects of medicine. And if you've been practicing as long as I've been practicing, you tend to just roll with the good and roll with the bad. Whichever one comes your way, you tend to just try and manage. It's not easy telling somebody who has spent so much money that none of the embryos you have in your panel is good enough for transfer. But the truth is the truth. There's no need lying about what is not there. I think the best thing is to be as contrite as possible, sit them down, explain to them what the findings are, and we move on. It's very difficult to move on from there, but to move on from there. But even before then, there is a process, to doing the even PGT, and there's extensive counseling before we start, because we don't just start taking samples without talking to the couple. We even let them know from the beginning what the possibilities are. In IVF, it can be so bad that you might never get any egg. And when you get the eggs, they might not fertilize. When they fertilize, they might not cleave, they might not grow up to day 5. Those possibilities are explained even before we get there. And then even with the PGT process, we let them know that, yeah, we're going to biopsy so number of embryos. And it's possible that of all the embryos we biopsy, we don't get anything. If that happens, what do we do next? The next thing is to try again. I know it's expensive, but we don't want to believe that that person only will be able to produce embryos that have abnormalities. There's always, when they're young, there's always that possibility that if you try again, you will get whatever it is you want. But even at that, even when you get the good embryos, what if they don't implant when you transfer into the uterus? Because that's a possibility too. It's never 100%. You do your best, but always what you try to do is to carry the business along from beginning to the end. With by the time we've counseled before, we are counseling during and counseling after. Everybody is on the same page, and there is no story. I remember there are some instances where even the clinic from outside the country, sometimes we'd love to call the couple and talk to them to try to bring them to the same page. Because if everybody is on the same page, it makes it easier. One of my profs used to say that the patient that will sue you is the one that you've not communicated well with. So if you communicate well enough, everything is written down, all the consents are properly signed, everybody, there will be no ill feeling at the end of the day because everybody has been told that this is a possibility. It is rare. It doesn't happen all the time, you know? So let's not cloud that, you know, with this discussion. If the majority of patients that we've had have also had good enough embryos to transfer. So that's, but there will always be the one or two or the few ones that don't have any suitable embryo to transfer. And we just have to be as truthful as possible, as contact. Just let them know, look, this is what has happened, and this is what we intend to do. It's a very difficult discussion to have, but it's got to, we just have to come out and say the truth. You know, we don't beat around the bush when it comes to things like that. And then after that, we also said, I mean, of course, they'll go for counseling again, you know, like a post-procedure counseling to let them know, you know, what and what has happened and what we intend to do in the future. I think that's how to go about it.
Are there financial aids, like some form of discounts or any other?
Yeah, definitely. For many of those, especially for the IVF part, there will be discounts, definitely. There's always that, you know, we provide some kind of discounts. But like Mr. Wilson said, health insurance, you know, may be a way to go, even though I know that many providers don't offer service for fertility. Once they have fertility, they run away. I don't know whether there's any change now, you know, with that kind of attitude, but we're hoping that as time goes on, you know, some of these health insurers will take it up. What about government? The financial burden is also on government. Are they doing anything to even make it easier for citizens to access services like this? Are they giving clinics concessions? You know, you want to bring in machines to do this kind of thing in the country, you want to bring in reagents, you want to do so many things. But I mean, when you get to the ports, are there concessions for you to make those things easy to bring in? So these are the kind of things that discourage people from even investing. But we are not discouraged. We will continue to do what we do and hope that we're able to provide good service to those clients of ours that deserve it. So okay, that's my own take.
Okay, Dr. Ajayi, as regards...
Person says, Dr. Ajayi, what is the difference between PGT and PGS? I'm not sure if Dr. Ajayi is the right person for this. More like Mr. Wilson's question.
Okay, I think he can answer on my behalf. I've talked too much today.
Okay, the difference between PGT and PGTS. PGT is the general name that covers for all the tests. That's the PGTA, PGTM, and the PGTSR. So the structural arrangement, but maybe is the person also trying to ask what is PGTM and PGTA. So the S there is just for screening, looking at the chromosomes, and you know, looking if the number of chromosomes are intact and they are fine. But because at times you have some trisomy, monosomy, meaning that instead of probably 23 chromosomes, you have more than 23, or you have less than 23. That's just the screening. But when you talk about PGTM, so there are some genes that actually are responsible for some diseases. So, you know, those genes are actually targeted. So that's PGTM, that's a monosonic, monogenic monogenic disorders, which means those genes are targeted and screened So it's not the whole chromosomes they are screening. They are looking for a particular gene that is causing a particular disorder. And when they screen it and they are unable to find that particular disorder, you can now say that embryo is free from that particular thing you are screening it for. So that's the difference between the PGTA and the PGTM.
I think the question was what between PGT and PGS, Abi?
PGT and PGS, yes.
I think it's just a nomenclature, you know.
It's just nomenclature, as I said.
People don't use PGS anymore. Just go and say PGT, and it's just PGTA, PGTM, PGTSR. So it's just the name. It's just people we're not trying to sort of standardize the language so that people don't say the wrong thing. Dr. Bankole is back. I think it must have been
he joined us right on time. There's a question here for him.
Okay.
One Professor Azu is asking from a population standpoint, is there any collaboration with the state or national ministries of health towards strengthening advocacy at PHC levels?
Well, infertility basically is not a priority area for, you know, government at primary care level. Basically, infertility cases who present end up at secondary care or referral centers, you know, and at primary care level, usually government focuses on infectious diseases, HIV, COVID, and all whatnot. You understand what I'm saying? So I wouldn't say there's really an advocacy. You know, meanwhile, infertility is actually a huge problem in primary care, actually, but there's no focus. The question is directed at collaboration between as advocacy of government. There's nothing like that in primary care level.
We have another question here. Is there sperm and egg banking infrastructure at the private and national levels towards addressing some couples with genetically linked pathologies who may still desire to raise offspring?
Is that question for me?
Dr. Ajayi, you can help us.
That's a very good question. And I'm actually happy that people are listening. Yeah, because there may also be situations where even despite all your best efforts, you know, you don't get good embryos from the couple. And in such instances, you might need to use donor eggs or donor sperm. And I can assure you that in many centers now, including ours, there's gamete banking facilities and embryo banking facilities. And I mean, we also, you know, offer donor gametes. So whether it's donor sperms or donor eggs for those couples that desire it. So it's available. And most of the fertility units in Nigeria now are privately owned. You know, I'm sure that many of them have gamete banking facilities. I don't know about the government facilities at all, but I won't be surprised if they also do. So as far as donor eggs and donor sperms are concerned, those facilities are available virtually everywhere in the country. That is at the private level. I can speak for the private sector, you know.
Dr. Bankole, you see these couples, I had asked Dr. Ajayi earlier, and you refer them. So when some of them come back to you with unfavorable results from their genetic screening, what support is available for them? What do you advise them to do?
Okay, well, it depends on the outcome of the tests, genetic testing, and, you know, and basically what they get is counseling. What they get is counseling. From experience, it's a bit more difficult for couples to accept donor embryos or donor gametes that will give them healthy, but with proper counseling, proper information, empathize with them and counsel them, and and just remove that psychological that this one is not a part of me. It takes time, but eventually they come around to it. So basically, we just give them support, give them information, make them see reason why they can go in the donor direction if it is unfavorable, if the result of the test is unfavorable. It's a bit difficult, but with proper counseling, proper support for them, eventually they come around to it. Not long ago, IVF wasn't so popular in our country. It wasn't so popular, but a lot of people are catching on to IVF. I've seen couples that were married for just 6 months and they're already talking about IVF. Out of choice. They just don't want to wait. Sometimes you even have to tell them to calm down because that's what they are informed already and they don't want to wait. So I believe with time, use of donor gametes, use of donor embryos too will catch on with time.
Well said. Thank you, sir. Before we go into the other questions, Mr. Wilson, I would like to find out, are there future advancements that we can expect in the area of genetic testing and IVF?
Yeah, there are new technologies coming up and new researches. Before now, we do biopsies, take samples from embryos, which from some quarters believe that it's to an extent a little bit invasive. Well, invasive relatively, because one, if you say it's invasive, but the embryo still, it has nothing to do with the viability of the embryos after you biopsy anyway, because biopsying comes with skills. But if you're able to biopsy and keep the embryo intact, yes, invasive, but you're doing the needful. But there are also technologies whereby they call it the spent media, whereby in the long run, you won't actually need to do lots of biopsy, because one of the limitations that we are having with PGT in Nigeria is the cost of the equipment. Like the laser machine on the ICSI machine is as expensive as the ICSI machine itself. So many centers are unable to access some of these services because they are unable to biopsy embryos. But with recent technologies, there are spent media whereby you don't even need to biopsy the embryos. You just need to take culture media in which you culture the embryos and send it for analysis, and the results will be out. So I believe now we are doing next generation sequencing, but I know there are newer technologies that will eventually take over that, which probably will be much faster, smarter, and make it eventually affordable and accessible to all. I know if we follow the route of the spent media, the cost to an extent might drop, but for now, I think that's the way to go at the moment.
There's a question here that says, I'm AS, my wife is same, our son is SS. We want to do IVF and bone marrow transplant for our son. What can we do and what is the cost?
Dr. Ajayi will handle that.
I will suggest they come in, for a discussion. The inquiry doesn't cost anything, come in, let's discuss, and we'll take it from there. Because it goes beyond just telling you a price in this kind of forum. It won't make any sense. I probably won't even be able to tell you how much it will cost to do a bone marrow transplant. The actual, because it depends on which center you go to get it done. But at least the initial part of the IVF and the PGT, we can sit down, discuss, and find a way to assist as much as possible, because I can imagine what you'll be going through already with a child that has sickle cell anemia. So I'll suggest you come in, let's discuss. Like I said, if discussion is free, nobody will ask you for any money. Let's talk, and we'll tell you what's possible and what's not, and we'll take it from there.
Okay, so for the person that asked that question, you feel free to visit Clearview Hospital. We'll give you the address before we close this webinar. Participants that have questions, you can also raise your hands and then we'll admit you to ask your questions. There's another question here that says, do you have genetic counselors doing the counseling for patients?
Yes, we do. Like I said earlier, you can't even do this kind of thing without having people that will do genetic counseling. The question is whether we have enough. I'll say no, we don't have enough. And we'll always advocate that people should go into training so we can get more genetic counselors. But before you can, embark on this kind of thing, genetic counseling is absolutely necessary. So everybody understands, from the beginning, what the possible outcomes are and how, we manage them when it happens. But we definitely need more, as much as we can get. Good.
Thanks so much for discussing this. We appreciate you for coming. Thank you so much, Dr. Ajayi.
Thank you very much for having me. That's okay.
Okay. I don't know if there is any other. Okay, Tola is back.
Yeah, sorry for that glitch.
Okay.
There are no more questions at the moment, and no one is indicating to ask questions. You can raise your hands if you have questions. You can follow Clearview Hospital on all their social media platforms at Clearview Hospital, Facebook, Instagram, Twitter, YouTube. And Clearview Hospital's address is 14B Mponu Wusu Street, Lekki Phase 1, Lagos. I don't see any more questions.
Yeah. Is Tola still there?
Thank you so much. Thank you, Mr. Olajide Wilson. We appreciate you for joining us. Dr. Bankole, thank you so much for taking time out of your busy schedule. Okay, sorry, we have one question here. I'm a doctor with patients, and how do I partner with you for my patients for IVF? Dr. Ajayi, we can't hear you. Please unmute your microphone.
Hello, can you hear me now?
Now, yes, sir.
Yeah, like I said, someone will contact him, offline to discuss. But like you said, we have 2 branches, both of them in Lekki. The first one is on Tayo Low, where you have the main hospital. The fertility unit is on Akim Dixon. The phone numbers are also displayed on all our social media handles, but if you want, I can give it to you. It's 0902 000 0647. That number comes directly to me. 0903 000 0647. If you call that number, I'm sure we'll be able to discuss. So we'd like to partner with everybody who wants to partner with us. We can assure you that we'll give you the best service. Thank you very much for your interest.
Thank you so much. Thank you, Dr. Bankole. We appreciate it. Okay, there's one question here. I'm from Ekiti State, from Afe Babalola University Teaching Hospital. We need training for IVF.
Mr. Wilson.
Anyway,
you like traveling.
Anyway, well, for training for IVF, it's something that is doable, though very challenging in the terrain we have now, because at times combining your lab with training, it can be cumbersome, but it's something we're looking at. I know Clearview is also seeing how we can work around this. They can still contact us directly. Let's see what is workable and see how we can.
We've had students from that school come for observerships and internships. So Babcock, Afababalola, they come in, but the training is not as easy as just coming in for 2 weeks and running away. You know, it's a long kind of training. So people are always welcome to come and see what we do and sort of develop an interest in IVF. So our doors are always open. Thank you very much. Yeah.
We hope to do this again soon because we see that people are very interested in this area of discussion. Thank you so much, Dr. Ajayi, for taking time out to be with us today. Dr. Bankole, we appreciate you. Thank you so much. Mr. Olajide, thank you. Thank you for being here.
You're welcome.
Thank you. Thank you.
Thank you, everyone. We appreciate it. Thank you. Good afternoon.
Good afternoon.
Good afternoon.
Bye.
Bye.